Hello friends, in this video I am going to talk to you about a very common day-to-day urogynecological problem which is about the lower urinary tract infection in adult ladies. This is indeed a very common clinical problem, but in a busy urology or gynecology practice, often it is misdiagnosed, and I would say often it is overdiagnosed and patient does not respond. So in this video, I touch upon what I call as pitfalls in diagnosis making. We will revisit some of our methods of making a diagnosis of this problem. Let us first see what is our intention as a clinician in a patient who is suspected to be having lower urinary tract infection. You obviously need a good diagnosis. The first part of which is to prove that the patient is having urinary tract infection. The second part is to find out why is this particular patient having urinary tract infection, and we actually intend to identify the predisposing factors, if any, in that patient, and also which is the offending organism. The third part of our diagnosis is to find out how bad, how severe is the urinary infection in that patient. Thus, there are three components, three objectives of our diagnosis making. And when this lady visits us in our busy OPD, and before we say that she has urinary tract infection, the methods that we use for this is history taking, examination of the patient, and some urinary studies. So for meeting our three objectives of diagnosis, you have three clinical methods. Now what we will do, we will try and look into where are those areas where one would falter if he or she is in a hurry. And we'll sequentially talk about the pitfalls that you can have in clinical history taking, then in clinical examination, and then in urinary studies. So when you are taking a history of the patient, what are those areas which you should not try to skip and we should not try to jump across? There are two lead symptoms of low urinary tract infection. One is painful urination and second is frequent urination. Patient usually have both, but patient can have one of these or one of these as more dominant symptom. Fever is usually not a very common symptom of low urinary tract infection. So let us first delve into this issue, the painful urination. Before you conclude that this painful urination is because of the UTI, you have to check out certain things. What I consider as the most important point before you proceed further is that you have to ask the patient at what stage of lower urinary tract function the pain is there or the pain is maximal. As you know, most of us remain in a pre-voiding state when bladder is filling up gradually. Then comes a stage when patient voids. This is called voiding phase. So it's a pre-voiding phase, it's a voiding phase, and then it is the post-voiding phase. So you have to ask from the patient in which of these three or more the pain is maximal. If patient experiences pain in the filling phase of urinary bladder, this is a case of painful bladder. And patient will say, after I pass urine, my pain becomes lesser. If patient experiences pain during voiding, this is called dysuria. If patient explains pain after voiding, and usually in the area of the external genitalia or around the urethra, this is a case of painful vestibule. Now this is key to the understanding of further diagnosis making. Where is the pain? In which stage of urinary tract stage is the pain? What I mean by this painful bladder? What should you ask more from your patient so that you clinch that diagnosis? The pain increases with the bladder filling. The suprapubic site is the commonest site of pain. As the bladder fills up more and more, the pain increases more and more. Some patients complain of pain in the area of clitoris and in the area of the urethra. This pain is relieved or reduced after passing the urine. So this patient, when you have these features in your history taking, please be sure that this is not a case of lower urinary tract infection. This is a case of painful bladder syndrome, some of which can be due to interstitial cystitis or something else. If patient has no pain in the stage of filling, but then patient says, as I start passing urine, as the stream starts coming out, I start experiencing pain, and during the time my stream comes out, I experience pain. This is dysuria. And you will ask on the patient, the pain starts with the voiding. It persists mostly during the entire act of voiding. Some patients have predominantly initial dysuria, and some patients have predominantly terminal dysuria. Now this initial terminal is in reference to the duration of urinary stream. This is because of urethrotrigonitis, and this may be UTI. We'll look into this little more deeply to say when do you think it is likely to be UTI. But this is a group where you can have UTI. The third group is, which I said, painful vestibule, but although this term is not mentioned in literature, and I like to call it this way, vestibulodynia, the pain in the area of the female vestibule at the end of urination. Here, the patients complain of soreness or some itching or some discomfort around urethral orifice after finishing the act of urination. And this is key point here. And this is common in postmenopausal ladies and diabetics. And this happens because the mucosa around the urethral orifice becomes hypersensate because of either withdrawal of estrogenic stimulation, mucosa becomes thin and unhealthy, or in diabetics there can be external genitalia inflammation, infection, which is not low urinary tract infection, but genitalia infection, which is low grade genitalia infection, and patients are often shy of speaking out this thing. So unless you ask this in detail, they will not tell you. So this is the pain in the vestibule. So friends, these are three phases of urinary tract where pain can independently happen. And everything is clubbed under the name of painful urination. Now, if you have initial dysuria, initial means as the stream comes, right then patient starts experiencing pain. And as stream flows, pain is there. But as the stream ends, pain becomes lesser and even vanishes. This may be due to a stricture in the urethra. This may be due to a caruncle at the level of external urethral orifice. Or this may even be due to some kind of low grade of urethritis, trichomonal, fungal, something like that. So remember these three common entities which can give rise to initial dysuria. Now this is not UTI, this is not UTI, but this is urethral infection. lower urinary tract infection. If patient has terminal dysuria, which means initial stream is relatively fine, but she experiences more pain as the stream ends, and this may be due to either a stone, and this stone may be in the bladder, vesical calculus, and more importantly, this stone may be in the lower ureter. And when you have stone in the lower ureter, there is an edema in the mucosa below the stone, right? And this edema increases because spasm in the ureter. And this edema gets transferred to the ureteric orifice into the trigonal area, and the periureteric trigone also gets inflamed, which is the cause of terminal dysuria. Some patients can have a carcinoma bladder sitting around or in the area of bladder neck. And some patients have inflammation in the area of the trigone, bladder neck or urethra. This is called trigonitis. Now here is a video of a patient wherein you will appreciate that the trigone is covered by whitish colonies of the inflammatory cells, wherein there are bacterial pods, and patient is actually having trigonitis. This diagnosis can be made by cystoscopy examination. So friends, when I say lower urinary tract infection, what actually do I mean? I mean that either the patient is having dominantly urethritis or patient is having trigonitis. So more often than not, it is a combination of urethritis and trigonitis, what is often believed as cystitis. In majority of patients, it is not a pan bladder inflammation. It is not that the dome, top, anterior wall, lateral wall is infected, and that's what is cystitis. In most patients, it is urethrotrigonitis. And this syndrome of urethrotrigonitis can happen not because there is an inflammation in the urethra and trigone, but because the urine that is flowing in the bladder is hyper-irritant. Or this can happen because the mucosa of the urethra and trigone is hypersensitive. So painful urination because of the source being in the urethra and trigone can happen either on account of hyper-irritant urine or on account of hypersensitive mucosa. Simple. Hyper-irritant urine means the urine is too acidic, and this happens in some patients who are having hyperuricosuriia. Or there are patients who consume lots of spices in their diet, and the toxins of spices come in the urine and make urine hyper-irritant. This is common in young girls particularly. Or somebody is consuming too much of caffeine. So friends, if somebody has a pain while passing urine, and this pain increases and decreases during the day, then be alert. This will not be because of infection. Because by rules of pathology, if the infection has occurred once, if the inflammation has occurred once, it's going to stay. It is not going to go away till you treat it. So if there's a dysuria because of infection, dysuria will happen in every episode of urination. But if patient says, sometimes after the breakfast I have burning pain, rest of the day I am fine. Sometimes it happens, sometimes it goes. When this is the feature in the patient, you are probably handling a case of hyper-irritant urine, not a case of hypersensitive mucosa. Or the hypersensitive mucosa will happen. It may sometimes happen because of radiotherapy given for cervix or something, or it may happen because of vaginitis. This is extremely common in our Indian patients. Co-associated vaginitis in various stages of inflammation results into neighborhood inflammation in the trigone and in the urethra. And when patient passes urine, she complains of dysuria. And ladies are shy of telling you about the vaginal discharge that they have, dyspareunia they have, genital itching they have, and they will only come to me as a urologist talking to me only about our urinary symptoms. So this vaginitis is to be looked into. And Third is the actual case of lower urinary tract infection. So what I said, even if you have a terminal dysuria, only some patient will have UTI. Many of them can have other differential diagnosis, which can be known only by a meticulous history taking. So dysuria, before you conclude the patient has dysuria and it is because of UTI, please remember, friends, about painful bladder and about painful vestibule also. So much so about the history that you must take when patient complains of painful urination, the main symptom, the first symptom that I said. The second symptom which I said is increased frequency of urination is the main symptom of the patient. Some burning, but she is passing urine too often in the day and in the night, and she thinks it is because of urinary tract infection. But here again, before you conclude, you check out. Check out what? Check out whether the patient is having frequency alone or she's having it with urgency. I hope you know these two symptoms and you can ask the patient about it easily. If patient has frequency alone, then this can happen on account of a rapid bladder filling, or it can happen on account of a small bladder capacity. A small bladder capacity will happen either on account of that the bladder has become actually very small, or on account of a functional reduction in the bladder capacity, which means it empties only half and half urine is left inside the bladder. So next time the bladder will fill up faster. So this is a morphological reduction in the capacity of bladder, and this is functional reduction in the capacity of the bladder. And then rapid bladder filling happens because of high liquid intake and high urinary output. So to look into this, what you should do in a patient of frequency alone, that you talk to the patient about the volume of urine voided, or I would say volume of liquid taken and volume of urine passed out. Both you should find out. If patient is producing high urinary output in 24 hours, and you can do this by monitoring a frequency volume chart of the patient, ask her to go home and come back in a day or two with a record how much time she voided and amount of urine voided during each act of urination. This is called frequency volume charting. By that, if the patient has high urinary output, it is not UTI. Or the patient here in a structurally small bladder will say, I void urine, low amount, every time the amount is same, small and fixed. But if it is a functional reduction in the capacity, patient will void small amount, but this amount will be variable. Sometime 100, sometime 150, sometime 200. But in a small bladder, it will be fixed all the time. And this small bladder happens commonly because of TB, radiotherapy, or interstitial cystitis. And this happens because of a combination of the problems like bladder outflow obstruction, underactive bladder, or a neurogenic bladder. So frequency alone can be easily found out by delving into how much of liquid patient is taking in and how much of urine she is pouring out. But if she has urgency as a dominant feature, has frequency of course, has nocturia of course, but urgency is a major symptom, then you have to follow the sequence of knowing the reason of urgency. Exclude psychogenic, exclude neighboring organ problem like cervicitis, vaginitis, or chronic constipation. Exclude serious neural disease like Parkinsonism or stroke in past. Exclude urine related issues. So, and then exclude lower urinary tract disorders, cancer bladder, stone in the bladder, and things like that. So this is how a frequency urgency syndrome has to be approached. So then this is all about the history taking, right? Now let's move on to the second block of our diagnostic method, which is a clinical examination. And I must confess that in a patient of low urinary tract infection, this step is often omitted by most people. Partly because they're busy, and partly because they are not aware, and partly because they don't think it is needed. and it is where there is a problem. So what you need to know, you are actually doing this examination with the intention of looking into, is there a predisposing cause for UTI? This is the reason why you want to examine the patient. And the predisposing factor, I mean, in an adult lady, often the infection is sexually acquired following a coitus, what's called honeymoon cystitis, or many ladies have postcoital exacerbation in low urinary infection, or it is in pregnancy, or it is because of PID, vaginitis, cervicitis, or some patients have obstructive urinary disease, which are acquired. By that I mean either a stricture in the urethra or the bladder neck obstruction in the ladies. So because of these reasons, the patients keep getting infection. It may be first episode, it may be a recurrent episode. But when you have an elderly lady and you're trying to look into what are the predisposing factors here, the top three are not relevant, right? Sexually acquired, pregnancy, PID are not relevant. What is relevant here is obstructive urinary disease become more common. Postmenopausal urethral senile stenosis is very common. A neurogenic bladder dysfunction is very common. A catheter as a source is very common. And a genital prolapse resulting into loss of urethral seal is also a common factor. So then these are the predisposing factors that you can have. And sexually acquired you cannot detect, of course, by examination. But rest all you will pick by examination only. So if you examine the lower abdomen of the patient, you may sometimes discover a full bladder, and this patient is having chronic urinary retention, because of which she is having persistent urinary infection. Or when you examine her urethral orifice, you may see a urethral carbuncle, you may see a bad case of carbuncle, you may see a urethral carcinoma, you may see a senile urethral stenosis. So what is this? Unless you examine the urethral orifice of this patient, you would not know whether is she actually having UTI, or if having UTI, what is the predisposing factor. So this is about examination. The third component of our diagnosis method was the good urine analysis. And this includes a routine urine examination, microscopic urine examination, as well as a culture and sensitivity test. The third part, the urinary studies. And you do this study with the intention of determining the actual presence of urinary tract infection, right? So, and the way we do, whenever we see a symptomatic patient, you immediately order for a urine analysis to look for pus cells, and you send urine sample for culture and sensitivity. So these are two urinary studies that are commonly done. You should know that there are more relevant urinary studies that do in urine examination, like looking for nitrites in urine and looking for leukocyte esterase in urine. Please pay attention to these two features also. They are often present positive in a patient of urinary infection, not in other cases. But it's a common trend to focus more on pus cells and more on positive culture and sensitivity. Now let me talk to you about this pus cell for a while. What is this pus cell? And see, if you see this policeman, see what I'm trying to do for you. I'm trying to tell you the difference in a leukocyte in urine and a pus cell in urine. The leukocyte is a normal cell and a pus cell is a damaged leukocyte. Why? Now, if you have this policeman nicely dressed, doing duty, but not involved in a combat, right? Just there on the duty, it's fine. But when the policeman gets involved in a combat to fight against an attack, the uniform is torn, maybe the belt is broken, or he's fallen on the ground and his equipment thrown here and there, and he may even be dead. How do you identify a policeman who is not involved in a combat vis-a-vis the one who is involved in the combat? You follow this by looking at the appearance. Same thing is for the leukocyte. When you look at the leukocyte under microscope, And when under microscope you find normal looking cell, bilobe nucleus, this is a leukocyte in urine. It is called leukocyturia. It has not taken part in fighting a battle against a bacteria. It is just there. It may happen in patients of stones. It may happen in patients of cancer bladder. So this is called leukocyturia. But when you have this leukocyte fighting a battle with the bacteria to eradicate infection, and then this cell shows you those features of change in the appearance. This is disintegrated nucleus, toxic granules in the cytoplasm, damaged cell membrane, the cytoplasm is showing phagocytosed bacteria inside, and then the cell becomes really large and irregular. It is something similar to the policeman showing you a torn uniform, broken belt, and fallen on the ground, and this leukocyte may even be a dead leukocyte, and then this is called pus cell. So friends, please be clear about this nomenclature. What is leukocyturia and what is pyuria? It is pyuria which is important for UTI, not leukocyturia. The second question. Often I have seen my friends looking into the report and also the patient relatives. There are 10 pus cells in urine. I am having infection. When they are treated and the report is done, they come back very anxious. Doctor, my pus cells were 10 before, now they become 20. Is my infection increasing? Now this is a very, very common mistake. Is the number of pus cell in urine related to the severity of UTI? Now friends, if you see in the urine sample number of pus cells, which is in the centrifuge urine sample, you look into the precipitate under high power microscope and count the number of pus cells. Now if the patient has taken a differential amount of urinary volume, which will depend upon the intake of the liquids, right? So at one time urine is concentrated, at another time urine is not concentrated, or else patient is having intractable frequency in urination. Sometimes he ejects out 10 pus cells, sometimes he ejects out 20 pus cells. So the number of pus cells are variable in the urinary sample, and on account of these two factors, the number of pus cells have no relationship with the severity. If you have a 5-10 pus cells, or if you have a field full of pus cells, right? If your scale of differentiation is so much, then it is different. But if it is 5 cell, 10 cell, 15 cell, this is not important. Then comes the culture report. And culture report is a test qua non to pinpoint the diagnosis of urinary infection, and you know these bacteria and you know the test, the way it is done, culture and sensitivity test. But then the place where you falter very often, you do not tell the patient how should she collect the sample. And the best way I found out is, I made a video of how to collect a sample of urine for a lady in Hindi and English. There's a barcode. This is what is given to the patient. Ask her to scan this barcode, listen to this video, 5 minutes, and then give the urine sample. This will tell you the way a proper sample collection should be done, the midstream urine sample collection. And then when culture report comes, what is this critical number to call significant bacteriuria? We have been taught all that 10 to the power 5 is the crucial number, but this has today changed. There is no fixed bacterial count that is indicative of significant bacteriuria, which can be applied to all kinds of UTIs and in all circumstances. So, because the clinical picture is so variable, clinical scenario is so variable, patients are so variable, having one single criteria is not proper. So what we do today is, for acute uncomplicated cystitis, the count is more than 10 to the power 3, not 5, of midstream urinary sample. For acute uncomplicated pyelonephritis, it is more than 10 to the power 4 colony forming units per ml of midstream urine sample. And for a complicated UTI, this is 10 to the power 5. So please see the clinical syndrome which you are suspecting, and on that basis relate the culture sensitivity report and the colony count. What I want to submit to you, when you see a urine culture sensitivity report and a urine report, friends, Please take assistance from them, not dictation. What mistakes some people do, the moment they see culture positive, they look at the antibiotic profile and they pick up anything from the top. Amikacin injection, start immediately. Augmentin, start immediately. So that's what should not be done. Take assistance from these reports. There are fallacies in these reports. It is better to repeat culture sensitivity. I have seen n number of patients having minimal symptoms, showing culture positivity, having tons of antibiotics by different people, and the fact remains that the methodology for urine collection was not right. And the third part of diagnosis was quantify severity of urinary infection, which you know already, uncomplicated and complicated. And complicated is because of, why it is complicated? It is because of either the organism is too virulent or there is a reduced capability to throw out bacteria from urinary tract on account of these things, or the host is susceptible. Host cannot fight against the infection. And these three things, one of them, two of them, all three of them makes urinary infection complicated, and that is should be done in every patient of urinary infection. So I hope I have made my points clear that what are those areas in history taking, in examination, in investigation of urine, which you must do in each and every case to not overdiagnose or underdiagnose a case of low urinary tract infection in a lady. Thank you very much. In case you have any question or comments, you can write on my email.